Welcome to today's session with the clinical exchange hosted by the Global Health Network. We'll be starting shortly, possibly in the next 3 minutes. As you can see on the map, this is a pictorial depiction of all the different participants from all across the world. And I believe today we have about 200 plus participants, which is really encouraging. But just to welcome you again to this session where we'll be looking at the WHO neurology revolution and looking at some of the challenges and opportunities in managing epilepsy. And we have a whole host of speakers this afternoon, and we'll introduce them as we go along with the course. And we'll have a time where we'll have a panel discussion and have some interactions with some of the delegates all across the world to ask pertinent questions regarding neurology. So perhaps as we wait, as we give it 1 more minute, if you could please type your name in the chat box, say hello, say where you're from. And during the course of the talks and the sessions, especially when we're having the panel discussion, feel free to type in your question and we'll read it out loud to the panelists so that they can address the pertinent issues regarding neurology. All right, our chairperson for this afternoon is Professor Gagandeep Singh. He is a professor in neurology with expertise in epilepsy and neurological infections. And he trained in epilepsy from the University College of London, UCL, at the Institute of Neurology. And he has nearly 30 years of clinical as well as consulting experience in his field of expertise. He's an active researcher in epilepsy and a recipient of over 10 international awards and national grants. And he's currently the president of the India Academy of Neurology. I would like to welcome you, Professor Singh. Thank you.
Thank you, Gareth. Thank you for the lovely introduction. It's such a great pleasure to be here in the midst of so many luminaries and we're talking on the IGAP, which I think is the big neurology revolution that we are currently witnessing. So today's session is about the IGAP, what the IGAP is, and some very good examples of what the IGAP is about with country examples from Malawi and others. So ladies and gentlemen, Gareth, if I'd share my slides, just a few introductory slides. Yes, so can you see my slides?
We can.
Yes? Yeah. So friends, let me begin with Malawi. And the year is 1989. And we have Dr. Watts, who's an Irish woman, Christian missionary, who came into Malawi to help the people there with medical expertise. And she wrote as such about epilepsy in the British Medical Journal, 1989. So in Malawi, people spend, quote unquote, in Malawi, people spend much time and effort traveling from one traditional healer to the other in search of help. And they end up using a variety of treatments, for instance, roots, to induce purging and vomiting. And the same roots are used for bathing. And mind you, the bathing is not done in the usual place, but in a rubbish pit, just to emphasize the kind of discrimination and stigma that was prevalent at that particular time. And Dr. Watts noted that in the beginning, attempts to publicize her epilepsy clinic by word of mouth were not very fruitful. And you can see from this graph of numbers, there were very few people with epilepsy who visited her clinic in the beginning. But then suddenly the numbers tipped. And what was the secret of her success? Well, she put it up point-wise in the paper. She publicized the availability of treatment. She educated patients and staff. used a simple regime comprising of phenobarbital, ensured that there was an adequate supply of drugs. They were provided free of cost. She made sure that there were monthly review clinics and that the patient always saw the same healthcare worker, not necessarily a doctor, but any kind of healthcare provider. Ladies and gentlemen, 1989, and it is 2023, and we know that still there is a huge epilepsy treatment gap in many resource-limited, low and low middle income countries. This is just a graph showing the kind of treatment gap, still about in the tune of 70% or more in the low and middle income countries. You can see the progress that has been made since the 1980s to 2023. Huge progress, particularly in Africa, as compared to Asia, which is more or less stable. The slope of the graph speaks all. And indeed, good progress made, particularly in the last 5 to 10 years in many of the low-income countries. But still, there are huge gaps. The IGAP is all about, bridging the epilepsy treatment gap, and it's the intersectoral global action plan for epilepsy. And these are some of the historical milestones that have eventually led to realization of the IGAP, beginning with 1997, when the global campaign against epilepsy was adopted jointly by the WHO, the International League Against Epilepsy, and the IBE, International Bureau for Epilepsy, Out of Shadows campaign. 2008, when the WHO came out with the mental health gap program. The WHO, again, in conjunction with the International League, as well as the IBE, undertook a demonstration project, very highly successful demonstration project in China. And this formed the basis of further demonstration projects in Ghana, Mozambique, Myanmar, and Vietnam. And then eventually in 2020, when the IGAP was first tabled to the World Health Assembly, in 2022, further refinement, it was eventually adopted by the WHO Executive Committee, and finally in May 22, when it was approved and adopted by the World Health Assembly, finally. So that's the story of the IGAP. It has 5 objectives, and each objective has 2 targets. And you can see in this beautiful summary slide, and epilepsy happens to be the entry point. And these targets are something which need to be achieved by 2030. So we have about 7 years, basically scaling up the reporting of neurological disorders, neurological services as a part of the universal health coverage, and the countries having brain health promotion and prevention. And when we talk of epilepsy, something like 25% of epilepsies are amenable to primary prevention. And these services need to be increased and scaled up by 50%. And then the other thing is about legislation. And that's something that's a huge gap: laws, legislations, and policies regarding epilepsy. Ladies and gentlemen, let me take you from Malawi to India and Karnataka, which is where this beautiful paper was published by Dr. K.S. Mani in the Lancet in the 1990s. And this particular slide summarizes, this was in rural Karnataka, and about 350 subjects. And this summarizes essentially the steps adopted or described in the methodology of the paper. So basically, paramedical workers brought people with epilepsy to the clinic, the rural clinic. It was in the village, which comprised of 3 specialist neurologists, a couple of social workers, a pediatrician, who confirmed or not a diagnosis of epilepsy, which was made entirely on clinical grounds, largely due to the lack of facility for EEGs as well as MRIs or CT scans. And the drugs, anti-seizure medications that were used was mainly phenobarbital, but sometimes also phenytoin, given once a day only in the least effective dose, managed by primary healthcare workers. And the entire management was in purely clinical. And the results, a 2-year remission rate of 65%, which is really, really amazing and fantastic. So the question that comes up is, does epilepsy need exclusive diagnosis and treatment facility? The answer in one of the papers, in one of the position papers, is clearly not, because simple protocols exist for primary care. Specialists, of course, have an important role, and they can provide training, referral networks, technical advice, how to go about things, doing a lot of hand-holding. But we can really strengthen the existing healthcare systems to treat epilepsy, to bridge the treatment gap, bridge the diagnostic gap, and make a huge, huge difference. So, ladies and gentlemen, if I would like to conclude, and this is a little provocative, and I'm sure it is provocative, and I would invite the views and comments of everyone later on during the discussion. But in situations where seizures are likely, and this is my viewpoint actually, in situations where seizures tend to recur or are likely to recur, it is appropriate to start the most appropriate, available, and affordable anti-seizure medication, rather than to wait for more investigations or specialist opinions. I think this is extremely important because for several reasons, and one of the reasons is that there is a huge burden of epilepsy, something like 50 million people with epilepsy around the world, of which 80% live in resource-limited settings, low and middle-income countries. And in these countries, the treatment gap is immense, nearly about 70%, 2/3 to 3/4 of these people remain untreated. Despite this, it's very clear that epilepsy is easily treatable. And roughly about 70% of people with epilepsy will experience very good seizure control with simple regimes comprising of anti-seizure medications, which are very easy to administer, which are simple, uncomplicated. And if untreated, epilepsy is associated with a premature mortality, something that is about 2 to 3 times the general population. So, friends, if you can understand that these are some of the facts about epilepsy, these are some of the reasons why epilepsy has been adopted as an index condition, as an entry point to the reduction of burden of so many other neurological disorders as a part of the WHO Intersectoral Global Action Plan for Epilepsy and Other Neurological Disorders. With this, it's my great pleasure to invite Dr. Phiri. Dr. Phiri has the distinction of being the first adult neurologist in Malawi. I believe there is already a pediatric neurologist. Dr. Phiri trained in South Africa, and after her training in South Africa, came back to Malawi and is now practicing as an adult neurologist. She sees a range of disorders, and I was telling her, I can understand how challenging, difficult, but at the same time, very interesting to be the only or the first neurologist, adult neurologist in an entire country. So Dr. Phiri, it is over to you and for your excellent presentation, and we're all ears for you.
Thank you. Thank you. Let me just share my slide. Oops. I hope you can see my slides.
We're just seeing your folders at the moment. If you could
Okay, let me just stop share. Yeah, and then share screen again.
Yeah, that's great.
Okay. Can you now see the slides? Okay. Oh. Yeah. Can you see them now?
We can, just wait for me to go. We can't see it in the presentation mode.
Okay. Let me just go to slideshow. Share from current slide. Oh, come. Oh, there we go. I hope you can now see my slides.
We can.
Okay, thank you very much. Good afternoon. I'm Tiwonge, Phiri from Blantyre, Malawi. As Prof. Singh has already introduced me, thank you for inviting me to this meeting. So I'll talk about the challenges associated with epilepsy management in Malawi. And before I start that, I will just briefly tease your minds and ask a question about epilepsy-related deaths, if they are a problem in sub-Saharan Africa or not. What's your opinion about that? If epilepsy-related deaths are a problem within sub-Saharan Africa, what's your opinion? Whether it's true or false, what do you think about that? Interesting. So epilepsy-related deaths are not common in sub-Saharan Africa. So 39% thought it was true, and 61% of the participants thought it was false. So let's see what our answer will be as I present. So epilepsy affects approximately 50 million people globally, and 80% of people affected with epilepsy live within lower middle income countries like Malawi. And you can see that about 5 to 12 million people with epilepsy live within the sub-Saharan region, and a third of epilepsy-related deaths occur in sub-Saharan Africa. So you will see that in that case, the answer is true. It's a significant proportion that we are contributing to the deaths as related to epilepsy from this region. And the prevalence of epilepsy varies from region to region and population to population. But a study that was done in 2014 estimated that the prevalence could be around 9.4%. A study that was done in Malawi, it was a small community that was studied. It showed a prevalence of about 1 to 2% of epilepsy, which is a bit lower from what we do see from other African countries. There are several factors that contribute to the high prevalence of epilepsy in our region, like perinatal causes, central nervous system infections like neurocysticercosis, and traumatic brain injuries. And as Prof. Singh has already talked about the gap that we are all worried about, there is a huge treatment gap in terms of epilepsy within sub-Saharan Africa. And when we talk about the epilepsy gap, this is the difference between the number of people with active epilepsy versus the number whose seizures are being appropriately treated in a given population at a given point of time, expressed as a percentage. So, as Prof. Singh had already talked about this interesting study, so I find this study very fascinating because it was done about 30 years ago, but it was so well done, and the way she handled the epilepsy problem is so interesting and inspiring. So I will not go into the details as Prof had already said in his slide, but of note is that it was done 30 years ago, and you can see that after she started actively talking about epilepsy to the community, there was a significant improvement in the numbers of people coming to her clinic. And I look at the key actions that she did. So in this case, she developed an epilepsy clinic, and then the community was sensitized. She publicized this clinic to the community, and then she dedicated people to work in the clinic. And of note is that she took almost everyone, even laborers who were working at that clinic were involved in the management of epilepsy. And she made sure that it was the same people that the people would meet to increase familiarity, and people, when they're coming to the clinic, they would meet people they know. And then she had to look for medications. And in this case, she was using phenobarbital. And you can see that she had some good outcomes from that. So I feel it's a study that we can learn a lot from what happened in the past. And then we move forward to 2023. Malawi has improved. The population is now almost hitting over 20 million. The question is, how are we managing epilepsy, and what challenges are we encountering, and what solutions are we coming up with along the way? So briefly, currently, we have about 400,000 people living with epilepsy in Malawi, and these patients are seen at all levels of healthcare. At tertiary and secondary level, they are seen by nurses, clinical officers, and at times mental health doctors. At primary level, they are seen by medical assistants and nurses, and these are not specifically trained in epilepsy, and there are no designated special clinics for epilepsy. So patients will just pop in to collect medications, or if they have features that are suggestive of epilepsy, then they are reviewed and managed and followed up. Only complicated cases are managed at central and district hospital levels. And epilepsy workup in our setting is mostly done at central level because the district hospitals might not be able to image or do other things at that level. And we also have community outreach programs, which are done in urban and rural hospitals. Most of the times, it's a multidisciplinary team that goes to the health facilities or to the community to do the outreach programs. And then we have small non-governmental organizations dealing with epilepsy that also assist us in these community sensitization programs. At Queen Elizabeth Central Hospital, I run an epilepsy clinic, which is done weekly. We have 12 nurses, 7 of them are trained to manage epilepsy, and we do see at least 100 people in our clinic. I mostly review complex cases or new cases. So 30 years later, you can still see that we do have some gaps that are still existing in the management of epilepsy. And we have several challenges. And one of the main challenges that we have in our setting, it's cultural factors. So you'll see that traditional beliefs in our setting play a big role in the management of epilepsy. The diagnosis of epilepsy is not well accepted in our community, and it's associated with a person being possessed with evil spirits. Either they are bewitched by a close relation who does not wish them well, and people still believe that this condition can be cured by traditional healers who can use herbal concoctions. They put tattoo marks on them. So that's what most people believe in our setting. And there is a lot of stigma as well, which is perpetuated by the local beliefs, because people believe this is a spiritual condition. So most of the times people who have this condition, and that sometimes families can be discriminated against. And most of the times these patients end up being isolated. They cannot get married. They cannot go to school. Their lives are very limited at times, especially in the rural areas. There was a study that was done by Chiropola and his colleagues. There were interesting opinions from this study. People thought epilepsy was contagious. People with epilepsy have low intelligence. Children should be restricted when they're playing, and patients should stay home. And they thought traditional healers could cure epilepsy. So these are some of the challenges that we are facing. And we also do see patients coming to our clinics who are concurrently using both hospital medications and traditional medications. And with that, there's sometimes poor adherence, because at times they would go to the traditional healer when the medications run out. And then at times when things get worse, they come back to us. And we do see a lot of toxicity from these concoctions. and they can potentially also cause drug interactions. And thinking about it, you would think that just because people believe in traditional healers, that's why they are going there. But in some communities, like the study that I'm displaying here, it was done in Mangochi, a southern part of Malawi. The study showed that sometimes people go to traditional healers because of lack of antiepileptic medications from health centers, and sometimes the distance to the district hospital or the health center is too far and they can't manage to go that far. Then they'll just resort to the one who's closer to them. So in order to manage this, we have embarked on community sensitization programs. And these are done by trained health staff. We are also working with non-governmental organizations. We are organizing TV and radio programs just to sensitize the communities on what epilepsy is, how it's managed, and what the implications that could come out of using traditional medications. And our sensitization programs are short-term, but long-term sensitization programs would be much, much better. And this is just a picture showing you some of the community NGOs that we work with to manage epilepsy. The other problem we are facing are treatment-related challenges. So we have recurrent antiepileptic drug stockouts. So patients will be changed on the drug regimen quite frequently from time to time. And then we also suffer from limited availability of treatment options. So phenobarbital and phenytoin are the main medications that we tend to use. Carbamazepine and sodium valproate are rarely available. And in order to work out around that, we have some NGOs that help us with lamotrigine and Keppra. And sometimes when we are very stuck, we'll send our patients to other facilities that also deal with epilepsy, like DREAM, so that patients can get medications from there. And we have also worked with the Ministry of Health. We have improvised the Malawi Standard Treatment Guidelines and essential drug lists to include sodium valproate, Keppra, lamotrigine, and carbamazepine as well. And then we are also engaging epilepsy activists, especially when we run out of drugs. They are very crucial in trying to make more noise so that the government can buy drugs and make the supply more consistent. And then we have diagnostic challenges. We have got limited imaging options. So we do not have EEGs. We cannot monitor drug levels in these patients. So that's one of the challenges that we are also facing. And we tend to get most of our assistance from our other stakeholders like Wellcome Trust, Johns Hopkins Project, and also DREAM. The other challenge that we have is that we have a shortage of qualified personnel. So you'll find that neurologists are not mostly available here. So we only are 2 of us, as Prof. Singh had introduced me. So there's 1 pediatric neurologist and myself. However, we have trained health staff that assist us with the management of epilepsy in our state. And the solutions would be to train more people in epilepsy management. And when we talk about training, usually we lack funds, and we cannot manage to train maybe more neurologists or more senior people. So we tend to do short training courses for the people within the community, like health surveillance assistants, medical assistants, clinical officers, and community nurses. So these are the people that we are mostly training to assist us with management of epilepsy. And we do receive support from other non-governmental organizations and stakeholders, like DREAM does assist us when it comes to need for training of workers to assist us in this aspect. And then the other issue are socioeconomic factors. Most of our patients are poor, they're subsistence farmers, they don't have enough money to even buy medications for themselves. And sometimes traveling to the health facility or going off work to collect medications is a problem. And to go around that problem, at our clinics, we do prescribe medications for long duration of times. Sometimes we do give them supplies for up to 6 months or 9 months. And sometimes we allow relations or anybody who's coming to town from that area, if they are unable to come, to get their health passport or their card for the clinic, we give medications, and then the medications can be brought back to them. And the long-term plan for this would be to make sure that our health facilities at primary level are well stocked with medications. So in conclusion, epilepsy management remains a challenge in our country. More research on this condition and collaboration between various stakeholders could improve the management of epilepsy, and community engagement to improve acceptance of the condition as a disease and to deter stigma would be crucial. Thank you.
Right. Thank you, Dr. Phiri. Thank you. You're doing a great job, and I think it is indeed such a huge challenge, and you're surmounting it very well. So thank you for the lovely presentation. We have, so if I were to ask you a question, can I ask you a question? I mean,
yes.
What is the one factor that is most important, amongst all of these? You did mention distance, you did mention the lack of specialists, and then last, not in the least, is the availability of anti-seizure medication. So what do you think is perhaps the most important and most crucial in terms of reducing the epilepsy burden?
So the most crucial in our setting, I think it's the traditional, the cultural bit. The cultural bit plays a very big role. Yeah, the cultural bit plays a very big role, because we do see that even though we are seeing a number of patients that we are having, but there could be more that would reach. But even the ones that we are reviewing, it's very hard for us to dispel the cultural beliefs in them and to encourage them to be adherent to our medications. So the cultural bit it's quite a big thing in our setting. Yeah.
And the other thing I wanted to ask is, how common is it that you take resort to neurological investigations, which means, for instance, a CT and MRI? You did mention that you do not have access to EEG.
To EEG,
right?
yeah.
So how often would it be that in people with epilepsy who come to you in the clinic, how often would you do imaging in these people?
So to be honest, Prof, I image very few patients, actually. Yeah, I image very few patients. Maybe out of 10, maybe 2 or 1 out of them. So we are mainly using clinical criteria to manage these patients. Yeah, so we image very few of them. Yeah,
that's exactly the point. Is epilepsy is one condition where you often need not, I mean, yeah, it's ideal under ideal circumstances. You need to have the entire a lot of investigation facilities. You can certainly initiate treatment in these people without recourse or resort to esoteric investigations, MRIs, CT scans, EEGs, and still a good majority of them would experience good seizure control. So
yeah,
is that what is that a message that you would like to give?
Yes, Prof. So the message that I would like to give to everyone who's listening is that, as Prof says, epilepsy is mostly a clinical diagnosis. And the other investigations could just be auxiliary, but you don't necessarily need to have all those investigations done before you start treatment. You can start treatment and patients can be stabilized without most of the investigations. And in our setting at Queen's, we do maybe some of those investigations for academic purposes because it's also an academic unit, but you don't need to wait on those investigations to manage epilepsy. Yeah.
So we've had some questions coming in. Can I read them out to you?
Yes, Prof.
Something like DOTS therapy for tuberculosis, directly observed treatment for epilepsy.
Mm-hmm.
Do you think there is something like that?
Okay, like DOTS for epilepsy.
Yeah.
I wouldn't be too sure about that, but in our setting, most of the patients that we give them treatment, they are usually being given by somebody, and usually we are getting reports from somebody. So probably maybe it's some sort of a DOTS thing whereby somebody is directly observing if they're taking the medications or not, but it would be quite good in epilepsy for seizure control, making sure that they're getting the medications.
Yeah, I mean, it becomes really difficult, and tuberculosis is something where you do this for 6 months, and even there are issues about DOTS where it is being administered and believed to be highly successful. But then epilepsy is much longer and much longer treatment, so that's an issue. So there are a couple of questions about ketogenic diet. So do you have ketogenic diet in Malawi?
So, Prof, our population is, as I said, 85% of them are living in utter poverty. They can hardly access food. And unfortunately, it's also the population that is worst hit with this condition, epilepsy, because of infections, poor perinatal care, and the like. So in the public sector, we do not really see that ketogenic diet, but in private, we do see that. So in our setting, in the community, it's not common. It's not common, yeah.
Right, and there is another question. It says a one-time clinic or a trained hospital for India showed a treatment gap of nearly 50%. I think that is acceptable. And this is from Granita. Granita, are you there? I think this is, so we have Professor Mamta Singh, who was here, but I don't see her in the list. And so do you have something like this where you have a one-time diagnostic camp, a huge facility where people come in, you diagnose them with epilepsy, and then you tell them to start treatment. But the opportunity of follow-up is not there?
So at the moment, we haven't had such an opportunity. We are mainly running it at Queens, but our plan at the moment, we are working with a few non-governmental organizations to roll it out to the peripheral health facilities, 2 of them, and then we can see if we can achieve that. Yeah.
So something like outreach. So do you have some outreach facilities or outreach programs?
So unfortunately, Prof, unfortunately, at the moment at Queen Elizabeth Central Hospital, we do not have, but we are planning to start doing that. So I think the time that I was coming, it coincided with COVID-19. So a lot of things became very complicated. But now that COVID has phased away, we are planning with a certain non-governmental organization called Epilepsy Warriors, that starting from September, we'll start community outreach within Blantyre, working with Blantyre District Hospital offices, yeah.
Right, so more questions are pouring in, and so someone's asked, Katerina has asked, do you use, when you use Keppra, or levetiracetam, do you see a lot of agitation, aggression, suicidal ideation? Is that something that you see in Malawi, and how do you go about it?
So, Prof, we do have Keppra, And we have introduced it in our clinic to a number of people, just a few. I think at the moment we might have maybe about 20 or 30 of them that are on Keppra at the moment. Right. We have not experienced any suicidal ideation from any of the patients, although we are closely monitoring them. Some of the few complaints that they have come with Keppra, most of them, is a few have complained about fatigue. And the other challenge is that some of them have complained that Keppra is not working for them and they prefer going back to phenobarbital. But suicidal ideation has not been mainly a problem at the moment. Yeah.
So, Professor Lentur, I really like this comment and questions about, spirit possession in people with epilepsy and the cultural beliefs regarding epilepsy. And his question is, and I think it's a very relevant question and very important question, is what can we do as neurologists, or more appropriate, what can you do as the only neurologist in Malawi to respond to this challenge, and how you can actually end up engaging communities better with regard to epilepsy and with regard to misperceptions, misbeliefs, and malpractices or inappropriate practices regarding epilepsy. So what is your take on that?
So my take on this is that, as I said, that traditional beliefs are playing a very big role in epilepsy management. And this is being recognized by all aspects of the stakeholders managing epilepsy. The thing is, being alone here, I think I would need a platform whereby everybody is able to hear me at one point in time, so that I should be able to reach a lot of people. And what we have decided is that we are now using the radio and the television, because these are, people are able to access these. So people are able to access the radio, people are able to access the television. And although in Malawi, most people are not having a lot of income, but they have access to small phones that they can listen to these things, at least the radio. So what I'm doing with this group that I call Epilepsy Warriors is that we are being engaged in radio programs. And these radio programs are programs whereby we know a lot of people who attend to them. So either in the morning when people are going to work or traveling to work, or in the evening within around 6 or 7, when people are at home and eating, they'll be listening to a radio. And we are using the radio stations that are mostly used by people within the rural areas. So here we have Zodiac, we have the national television and radio station where we do these programs. And these programs are like the way we are doing, like group discussions where people ask questions and then we answer. And sometimes these programs can reach a point where they are like phone-in programs, where I will give out information about epilepsy that is true, and then they can ask any concerns they have. So we have seen some good outcomes from it. Wherever you go, people recognize you and say, you are the one who was talking about epilepsy, we know you. So that's what we are tending to use in our setting, to reach out many more people.
I'm sorry, Professor Leon, Massimo Leon, can you unmute yourself? And I'm sorry, we missed out you in some important discussions, and we would really like to have your views on this. So what is your view about how neurologists can go about engaging people in the community, improving attitudes towards epilepsy, and in reducing the epilepsy treatment gap? So what is your experience, and how do you think this can work out well?
I thank you for this question, Professor Singh. I know we know each other with Dr. Phiri, and let me add that she can be considered a hero in the country, as you underlined before. So, as a Western country-based neurology, this is a very good question, but this is a challenge, let me say, for high-income countries neurologists in general, and as you know very well. So, how we can help, what we can do as Western country-based neurologists for Malawi, for countries as Malawi, and in general for sub-Saharan Africa, because as you know, we are very much oriented toward basic research like genomes, brain imaging, and so on. So, but the need, the true questions from the ground are different. The real question is how to integrate the two needs. That means the two culture, because here in Europe, we as neurologists, we are trained on completely different methods in different settings compared to sub-Saharan African places where people live and should be treated. Okay, so here we are not aware, but above all, we do not have the culture. That means we are not prepared. That means IGAP is really great in the revolution because it's clearly a call to culture and then to action for us as Western country-based neurologists. Let me say that I have been very lucky because I'm working in Africa since more than 20 years and in Malawi since 2005, but not as neurologist. In the DREAM program that was started in 2002 to fight against HIV. And HIV has many similitudes with epilepsy because it is a chronic disease and it is patients are affected by huge stigma. So chronic disease is non-communicable chronic disease nowadays are a challenge also in sub-Saharan African countries. And epilepsy is one of these new, let me say, not very new needs. So the true question is how neurologists can we help? The first question is it's not only a matter of education. You know very well that standing alone course, teaching course are not enough because we know very well the phenomenon that the no-do gap. That means if you do a standalone course, sooner or later the health workers, doctors or not, will lose if she is left alone working, for instance, in rural areas or not. So it is very important to connect. This does not mean to give him an internet connection. First of all, I personally believe, strongly believe that we have to really to reinforce the human connection first. That means to try to establish a relation in order to have a common language. You can imagine my language as Western-based country neurologist, how much is the difference compared to a clinical officer working in Malawi in a rural area? Almost no way to understand each other. Okay, we are going in different direction, with different speed, with different language. So that means that on my side, I need to go there and to listen, to see. And this will take time, many times. So this is a challenge. That means we have to spend more time to go there, to see and touch, and to spend time with the health workers there and work together with the patient. I'm not saying something that is new. We know very well this from the WHO with the task shift and task sharing approach that has been published many years ago. So this is very important, to go and stay long-term program, not project. Again, as Western country-based neurologist, I am used to think and to work and act in terms of project. That means in terms of time, that is something that has a beginning, and sooner or later will have to stop. 1 year, at maximum maybe 2 years, 3 years. But epilepsy in Malawi needs much more. So I think that IGAP is a strong call to change mentality and to reduce, first of all, the cultural gap. That means we have to better understand the complexity. Just the last thing that I would like to add, that a patient with epilepsy, if well treated in terms of both management, in terms of drugs, in terms of behavior and so on, has the potential to show other people around the benefit from medicines, not only from herbs. So as a witness, I think that this is a very powerful tool that we have to work on. Okay, patient, witness. Okay, that's why we have to grant, we have to avoid stock interruption of drugs, because people spend a lot of money. One trip to go the 2 ways as a mean, it costs a lot. In proportion, it has been calculated that the cost for one patient to go 1 time to collect the drug is about 25 times higher compared to what we spend here in our area in Europe, in proportion. Okay, so, and this is a huge problem, you know very, very well. So we have to bring their drugs and to work with them in conclusion.
Thank you, Massimo. Thank you. And thank you for bringing out some of the important similarities between the diagnosis and treatment of epilepsy and that of HIV. And Professor Leon is very active in global neurology. He is the person behind the Dream mission. Am I right in saying that, Professor Leon?
Yeah, it's okay. Dream program.
Yeah. So, ladies and gentlemen, as we come to a conclusion, we've had a wonderful talk by Dr. Phiri, and clearly depicting the situation, the developments in epilepsy care in Malawi, which is a prototype for so many other low and low middle income settings, with some wonderful comments by Professor Leon. And if I were to sum up what Dr. Phiri essentially said is, neurologists can make a difference, but it's not necessary to have too many neurologists. Of course, that's the ideal situation, but even in the absence of many neurologists, we can actually do a great job. And she typically the example of Malawi, where there is just one adult neurologist, but with the help of so many other allied health workers, primary healthcare doctors, other primary healthcare providers, she has been able to diagnose and treat epilepsy, to help reduce the epilepsy treatment gap. That's a standing example. Dr. Phiri also emphasized the importance of continuous availability of quality anti-seizure medications. And that's a very crucial factor. And of course, engaging people in engaging communities in the kind of good work that she is, and that would really help in bridging the epilepsy diagnostic gap. It would help in reducing and mitigating stigma. Last but not the least, I mean, Dr. Phiri's work is a clear evidence, or is a clear testimony to the fact that you don't need high-end investigations. You don't need, you have someone with epilepsy, you make a clinical diagnosis, and it's a good thing. It's good practice to start treatment as early as possible, because these people can have recurrent seizures, and if they have recurrent seizures, they're at risk of injuries, they're at risk of premature mortality, and therefore the earlier we start treatment, the better it is, without resort to esoteric investigations, which may or may not be available. So that's the message. And if we've got to take the IGAP further, these are the ways that by which we can actually take IGAP further. With these comments, I would hand over to Gareth. Gareth, if you could take over now, and is there anything else that we need to say or do, or is it over to you?
I know that's fine, but just a big thank you to you, Professor Singh, for chairing such a lovely session, and to our speaker, Dr. Phiri, for just highlighting the overview of neurology and epilepsy in Malawi, and again to Professor Leon for just your insights on the multidisciplinary approach. So just in the last minute or so, I'll briefly share on some of the opportunities that are available within the scope of neurology. If you'd like to, if you're able to see my slides, yep. Right. Right, so with the Global Health Network Exchange platform, there's different opportunities which individuals can take to heighten some of the different knowledge gaps that are available, as well as different training opportunities and network platforms. And the clinical exchange model has been developed to allow different stakeholders and delegates across the world to dive into some of these resources. And one of them is the findaphd.com website, where it's a catalog of different PhDs, and there's different search engines that you can use to find a fully funded PhD, even within the discipline of neuroscience. And I think if you go on this website, you should be able to access some of these PhD courses, along with all the different details and institutes. We also have the Encephalitis Society, which has their annual conference this December on the 3rd and the 4th, and there are bursaries available. The deadline is today, the 30th of June, so if you do fancy to attend the encephalitis conference, do submit in your application. The call for abstracts is still available, and the deadline for that is the 15th of July. And just as a by the way, the Encephalitis Society offers free professional membership and access to grants and training, as well as annual seed funding of up to £10,000, particularly targeted to low middle income countries. There's also free online courses with Harvard University, where you can look at different aspects such as health and medicine, data science, education, and teaching, as well as social science. And just as a reminder of the different funding opportunities within the NIH, looking at the global brain and nervous system disorders, research across lifespans, and targeting different scientists in low middle income institutions to partner with scientists in the United States, as well as other low middle income country institutions. And the next deadline for this is November 2023. And there's many more other opportunities which we'll be sharing at each of the different clinical exchange sessions. But just a big thank you and acknowledgement to the different partners, particularly the WHO Brain Health Unit, as well as the University of Liverpool, for making these platforms possible, as well as all our speakers. Thank you very much. And I believe this marks the end of today's session for clinical exchange. And once again, a big thank you to our chair, as well as our speakers, for facilitating a very informative session on epilepsy and just the different overviews and outlooks and perspectives that are available. We hope to see you again in the next month And I believe if you've registered with the Global Health Network, you should be getting in the details of the next meeting, as well as the Zoom details. Thank you very much, everyone.